I would like to acknowledge that in this virtual environment, I am joining from the land of the Wurundjeri people of the Kulin Nation, and I pay my respect to their elders past, present, and emerging. As Nayland has mentioned, given that there's quite a variety of people in the audience today with a lot of different really interesting backgrounds, the information is quite general, and I've sort of tried to go into detail in certain parts, but please feel free to jump in at any point. If there's something you want more information on or you have any questions, I'm more than happy to make this, quite interactive and informal. So please feel free to ask questions whenever, either via the chat, and I'll try and monitor that, or just yell out. So in the next sort of 45 minutes to an hour, we're going to cover a few different topics. So the first one is a very brief overview on Hep C progression and why it matters that we manage and treat Hep C. And that will go sort of evolve a little bit from what Nayland was talking about this morning. We'll talk about transmission and prevention, testing and diagnosis, and then the good news story, which is treatment and cure for Hep C, some general treatment pathways, and of course, questions at any point. So why did it matter? And why are we here talking about Hep C? And Nayland and Jen have already done such a fantastic job, I guess, highlighting how important it is that we're addressing viral hepatitis as a health issue. And I think, as Nayland mentioned, that process of liver inflammation that can be caused by a whole lot of different things, Hep C is one of those things. So the Hep C virus lives in the liver, and it causes the liver to be inflamed as the body's trying to get rid of it. And over time, that inflammation can lead to fibrosis, to mild scarring, and more severe scarring and decreased function of the liver, which is that sort of cirrhosis. And that's a problem because that compromises liver function and health, and it also increases the risk of things like liver failures and liver cancers. And so someone living with Hep C, the risk of those things is much higher than the general population. And so, for example, we're looking at it about, and it is quite a slow progression. And there are some things that will speed that progression up. As I mentioned, there's a lot of co-founding things like, general health and alcohol, and some of those things will speed up the process of liver scarring. But generally, in about 20 to 25 years, we're looking at 20 to 30 of people with untreated, unmanaged Hep C developing cirrhosis, and then sort of up to 1 to 4% over up to 30 years developing liver cancer, and 2 to 5% developing liver failure. And whilst those numbers don't inherently sound that high, it is a much higher risk than the general population. So that's why it is really important that we're testing people and diagnosing people and then treating people. So Hep C transmission, and I'm mindful this won't be new to a lot of you, but there is a lot of variation between, I guess, what we'll talk about later with Hep B and then also Hep C transmission. And so Hep C transmission is purely blood-to-blood contact. So where there's a risk of someone who has Hep C blood getting into somebody else's bloodstream, that's a risk for Hep C. And that can look like a whole lot of different things, which is on the slide at the moment. The really most common route of transmission in Australia is through serum injecting equipment. And that's not just the needle itself, it's everything that goes with it. It's spoons, it's tourniquets, it's swabs. The virus is highly infectious, and it is something that only requires trace amounts of blood to be able to be transmitted. And so that is a very, very high risk scenario. And it's where we're seeing about 90% of new cases in Australia, and about 80% of existing cases have been transmitted through people who use drugs and people who share injecting equipment. The other kind of really high risk factors are what we call our backyard tattoos and piercings. So tattoos and piercings that are done in a setting that doesn't have proper infection control. And that is something that's increasing purely because it's actually really easy to get hold of a tattoo gun, for example. They're about $50 on eBay. And whilst people might think, oh, well, I'm trying to do the right thing, I'm swapping out the needle between people, I'm tattooing my friends and, all of that. Without proper infection control, that can still be a really high risk because it's also the ink pots, it's also everything they're touching. And so that's also quite a high risk as well. There's also some other risk scenarios, fighting where there's a risk of blood-to-blood contact. There's a lower risk, mother to baby, and we'll talk about this when we talk about Hep B more generally. But I guess just for some comparison, the risk of Hep C transmission from mother to baby is significantly lower than Hep B. But there is still a risk there with that blood-to-blood risk as well, and it's more during birth than pregnancy. And so that's some kind of really general things. Other things, anyone that's had a blood transfusion in Australia prior to 1990. So it was only in 1990 that we really recognised, or around that time, that we really recognised Hep C, something that we could test for. It was non-A, non-B, something that you might have heard of in the past. And so that's when they started screening donated blood products in Australia for Hep C. So whilst it's extremely safe now, prior to that, we do recommend that people get a one-off blood test. And also blood transfusions and medical procedures overseas. We have very, very stringent infection control procedures in Australia. Overseas, that's not always the case, so sometimes that can be a risk as well. The other thing that I like to talk about is kind of, I guess, being a bit of a priority population around Hep C is people who have a history of being in custody or in prison. And that's not because inherently being there is a risk in and of itself, but there's a few different factors. There's quite high rates in the prison population, and you can imagine that it often goes hand in hand with why people are incarcerated. And it also, there's lack of access to things like clean injecting equipment, and even things like, barber and tattooing equipment. There's a lot of kind of, I guess, the harm reduction access isn't the same as it is in the community. And so then the risk of transmission becomes quite high as well. And there is some great treatment pathways in prison in Victoria, which I'll chat about later when we talk about treatment as well. So that's a bit of an overview of transmission. And I also should mention, because we often talk about treatment levels changing and that kind of thing. And when we talk about people who inject drugs being, I guess, the priority population or one of the key routes of transmission, that reported level of sharing injecting equipment has remained very stable for about the last 10 years. And so a lot of you will be familiar with the Australian NSP survey, and that's showing kind of reported levels of about 10 to 12% of people who access NSP services. And so that hasn't changed much over the last 10 years. So it's definitely something that's still there. There's also a lot of misinformation and I guess myths out there around Hep C transmission among the community, and it can lead to a lot of, I guess, measures of prevention that perhaps aren't necessary, or just kind of misinformation, and increases some of the stigma around Hep C as well. So the images on the screen are generally not a risk for Hep C. Mosquitoes is a really, really common one that we hear quite a lot, and there's a few reasons why that's not a risk. One is because mosquitoes don't actually have a liver, so they can't carry the Hep C virus, but it's also the way that when you get a mosquito bite, it's a two-way system. So they're not biting someone else and then biting you. Sharing food, absolutely not a risk. Kissing, sharing toilets, holding hands, all that casual contact, not a risk for Hep C. The only thing I will mention with breastfeeding is whilst it is inherently safe, there is recommendations that if there's any bleeding, clucking, anything that there's a risk of blood-to-blood transmission, that breastfeeding is stopped until it's safe and healed, and then it's safe to resume. So before I move on from that sort of transmission and priority populations, does anyone have any questions about that? No? Okay, wonderful. So then going hand in hand with that, when you look at the different routes of transmission and those risks there, then we can start to think about prevention and what can be done to prevent transmission of Hep C and the associated health impacts. And the really big one that a lot of you will be very familiar with is, of course, encouraging access to needle and syringe programs. Access to clean equipment is the key way that we can reduce those Hep C transmissions. And obviously that is sometimes easier said than done. I guess a lot of you being in Gippsland will be probably very familiar with that there's some fantastic NSP programs, but compared to the sheer volume of access, perhaps in Metro Melbourne, it is not always that easy, but it is something that I guess, we'd be encouraging people to know where their closest NSP is, where they can access it, and why it's important. Education is also a really big one, and I think I'll talk more about this later when we talk about some of the misinformation about treatment and cure that's available, but also, as we've touched on with transmission, there is a lot of misinformation amongst people at risk of Hep C and also people living with Hep C and in the general community around why they might be at risk, whether or not they're at risk, how they can get tested, and access to treatment. And so it's something that we are, really strongly pushing for is, and this is why it's so wonderful to be able to do events like this, is because you guys can take this information away and share it with your clients. And that is going to have an impact on people's kind of, knowledge is power. And if people can have that information on hand and know where they can go, then that can also increase rates of testing and treatment. Treatment is prevention. I'm just going to briefly touch on. And so, as you probably can't, not if you didn't know already, there is a cure and a treatment available for Hep C, which means that, if we can lower the rates of Hep C in the community, and then that can obviously in turn reduce levels of infection. We're certainly not necessarily at that point yet, but it is something that's worth thinking about in terms of, the future and future goals. The other thing to touch on, and this is a bit more general as well, and whilst we're not going into detail in this presentation around the stigma and discrimination associated with Hep C, it kind of does feed into this topic around universal precaution. And so in terms of a healthcare setting, that prevention measures was really the most important thing, is the fact that, a lot of people either don't know they've got Hep C or may choose not to disclose that they've got Hep C. And so it is really important that we are treating every single person as infectious and following all of the same precautions as you would. And it's interesting, I think with COVID, this has become a lot more in front of people's awareness in the general community. Obviously in the healthcare sector, it's something we've been aware of and talking about for a very long time. But just things like washing your hands and PPE and, correct disposal of needles and syringes, and correct cleaning protocols and all that kind of thing is something that we're talking about a lot more, but that is also really important in terms of Hep C prevention. So then how does somebody know if they've got Hep C? And the short answer to that is by getting a blood test. But the longer answer is that, unfortunately, Hep C is a virus that can go undetected for a very long time. And that is because the liver is actually very clever and it's very adaptable and it will cope for a very long time without necessarily a significant amount of compromising function to the point where somebody has symptoms. And so often people who have not had Hep C for that long, and I'm still talking about years, can have Hep C for quite some time and often not have any symptoms. And if people do have symptoms, it's things like feeling a little bit tired, not particularly hungry, maybe a little bit nauseated. Something what we call this brain fog. People can't think as clearly as they perhaps have in the past. But I don't know about you. If I haven't slept very well last night, I might feel a bit like that too. Or there's a whole host of other health conditions that could point to any of those symptoms. They're very, very non-specific, and they can't be relied on for a diagnosis of Hep C. So it is really, really important that people are getting a blood test. And I also should reiterate that just because something might not be have symptoms, it doesn't mean the Hep C is not causing damage. Because when we start to see those kind of, I guess, more significant later stage symptoms that I guess are more well known, things like jaundice, pain, and kind of, starting to feel significantly worse, there's already a significant amount of liver damage, and it's that liver damage that's causing the symptoms. So to be able to prevent that damage from occurring, it is important that people are getting tested. So there's a couple of different blood tests for Hep C, and it's important that we're encouraging people to make sure that they're getting both of them. And there's a few reasons for that. So the first blood test that usually will get done for Hep C is a screening test, is what we call an antibody test. Now, when I talk about two blood tests, usually if somebody's getting tested and the person who's doing the blood test or ordered the blood test is familiar with Hep C, they will get done at the same time. So you don't get an antibody test and then that, as I'll explain, if that's positive, then you have to go and get the secondary test. You don't have to come back a week later. Generally, they will collect it all at the same time. But there are two tests that get run. And the first one is purely a screening test. And so it's what we call an antibody test. And that is just a test that is taken to detect whether or not the person has ever been exposed to Hep C. So it tests for the presence of antibodies, which the body makes in response to being exposed to the virus, not the virus itself. And that means that then if it's negative, that person's never been exposed to Hep C and they don't have Hep C. But if it's positive, it just means that at some point in their life they've been exposed to it. It does have a window period of about 3 to 6 months. It's probably closer to 3 months now, but we do say 6 months to be safe. But the thing is, somebody could have positive antibodies and they could have either had treatment and cured the virus and no longer have Hep C, but they will always still have the antibodies. Or they could be one of the about 25% of adults that their immune system will naturally clear Hep C. So some people who come into contact with Hep C won't go on to develop a chronic lifelong infection. Most will, about 75% will, but about 25% will clear that themselves. But they won't no longer have Hep C, but they will still have the antibodies. So if someone is positive to a Hep C antibody test, then they need to be getting the secondary PCR test, which I'll talk about in a moment. What is really, really important though, and this is one of those sort of points of misinformation that I mentioned earlier, is that antibodies do not equal immunity. And it is a bit confusing because there's a lot of viruses and different conditions where that is the case, but with Hep C, it's not. So there's actually no way that you can ever be immune to Hep C. There's no vaccine, and even if you've had treatment, you can still get it again. And I'll go into more detail about that later, but it's just important right now because a lot of people do think that if they've had it in the past or they've had their antibody test, they can't get it again, which unfortunately isn't the case. So if somebody tests positive to an antibody test, then they would go on to get a PCR test. And this is a test that looks for the virus itself, not just the antibodies. And this is the definitive test as to whether or not someone has Hep C. And this is what is really important, that we are making sure that people are being diagnosed based on a PCR test, not an antibody test. Because unfortunately, we do still hear about people who get told they have Hep C on the basis of an antibody test, and it's often many years later until they realise that actually they never had it in the first place. The PCR test will also go along with a lot of other kind of tests and assessments, including the viral load, genotype, which isn't something that is as relevant now with the new treatments, and I will touch on that, but it is something that we would usually still ascertain if possible. It did used to have a much bigger impact on which treatment people would be offered. And the window period on that is a little bit shorter. So if that's negative, then they've either cleared it or been treated for Hep C, or if they're positive, then that person does have Hep C. Before I move on to talking about treatment, does anyone have any questions about testing or anything that we've talked about so far? All right. I also just mentioned too that while the blood test is the test to diagnose Hep C, or oftentimes other tests will be done as well, and that's usually around assessing someone's liver function, where their liver's at, depending on how long they've had Hep C. And there's a few different tests around that. So one of them is a fiber scan, which again, some of you might be familiar with, but a fiber scan is essentially, it feels and looks to the patient very much like an ultrasound. It's a similar sort of technology, it uses a different kind of wave, but it's quick, non-invasive, and that is just gives us an indicator of what we call how stiff the liver is or how hard the liver is, which in turn gives us an indicator of how much scarring and damage the liver has. There's also something called an athlete test, which is calculated from a whole lot of like full blood tests and liver function tests that also give us a bit of an indicator as to how much damage that person's liver has. And there's also, and I'm only going to touch base on this, is very, very new, but it's also quite exciting that very recently the TGA has actually approved the first kind of rapid test that's available to be used, and that result can come back, in less than a day, if not hours. And that's very, very new and in the very, very early stages of being, I guess, figured out how that's going to be rolled out and utilised in Australia and Victoria, but it is something that will, I'm sure, grow in popularity and become more common in the future. All right, so treatment. Very exciting, good news story. And so as I've mentioned a few times and as we've touched on, there is treatment and cure that's available for Hep C, which to me just really reinforces how important it is that we are screening people and testing people and talking to people, because there's something really, really positive that we can do about it. And so the treatments have been available on the PBS since 2016. And so we keep saying new treatments, and I'm not quite sure when we'll stop doing that, because I think it is thank you, Jane, I'll get to that in one moment. They have been around for a while. And as Jen mentioned, there was a huge amount of uptake initially, and unfortunately that uptake has dropped off over time for a whole lot of different reasons. You can imagine that there would have been a lot of people waiting for these treatments, and they all were, engaged in care and got treated, straight away as soon as possible. And now it's about, how can we talk to people who perhaps, haven't had access to that information earlier or haven't been tested earlier, and how can we get them treated? And so there were treatments are what we call direct-acting antivirals, and they are a completely different drug to anything that you might have heard of in the past around Hep C treatment. If you weren't aware, the treatment used to be pretty difficult. It used interferon, which is essentially a chemo drug, as well as ribavirin. Neither of them are particularly tolerable drugs, and they also didn't work super well. Their treatment, their success rates weren't particularly high, and the side effects were really very difficult. And so as a result, treatment was, very limited. It was very hard to access. It was usually done, when it really needed to be, and there were a lot of restrictions on treatment. That is all completely changed. These drugs are completely different, and they are just tablets as well, so there's no injections, which unfortunately was a part of the old treatment. The side effects are very, very minimal, compared to what they used to be. We're looking at things that not even everyone will get this, only, but mild headache, maybe a little bit of nausea, and generally that will resolve after the first week or so of taking the medication anyway, a couple of weeks. Most people don't have that ongoing throughout the entire course of treatment. And so that course of treatment generally is about 8 to 12 weeks, and the treatment is up to 95% effective. And so it is usually works, and it usually cures people of the Hep C. For that 5%, there's generally a reason, not always, sometimes people can be very unlucky, but there's generally a reason, whether it's perhaps that they've not, for whatever reason, been able to take the medication the whole time, perhaps they've been retreated, and there is, and I'll talk a bit more about that in terms of reinfection, but there is actually a drug that is used specifically just for what we call salvage treatment, so to retreat people that have been unsuccessful, but there's usually a reason why. So the large majority of people are able to access cure. So I'm just going to go to the question in the chat before we move on too much further. Yeah, look, that is a really, really good question. And I think it totally depends on the person and the relationship that you have with them, if I'm being honest. I think most people who are involved, or most people who use drugs and most people who inject drugs are aware of Hep C, and they're aware that Hep C is a risk. They may not necessarily know all the nuances of transmission and what treatment's available and how they need to get tested, but it's probably not going to be a shock to them that it's been brought up. In saying that, there's always exceptions, of course, so it really is about the person. But I think in that setting, suggesting screening is usually worthwhile, and probably best practice if you think that they're a risk. Usually, and I'll talk more about this when I talk to kind of barriers to care and treatment, but usually them not getting a blood test or not getting treated isn't necessarily because they felt stigmatized by the question. It's generally due to other barriers, including, blood tests can be really, really difficult. People have a lot of different competing priorities. But yes, I do think that suggesting it is, and it can do is that this is something that we're asking everyone, especially if it's a clinic perhaps that has a higher caseload of people on, methadone, Suboxone, or people who use drugs, or even generally, this is just something that we're asking everyone. But when was the last time you had a BBB test, that kind of thing. Does that kind of answer your question?
Thank you. Yeah, we have a screening tools in the AOD sector, and it's definitely one of the questions.
Yeah.
We ask people if they've ever had a test for BBB, if they want a test, and if they want treatment information.
Yeah.
Often people who I'm aware of, they've told me that there hasn't been any IVDU. They will just say no, don't need to do that. So that's my, that would be my sort of concern as to whether or not I should be encouraging them to possibly think about it anyway.
Yeah, and I think it is kind of critical. There's the two things there, isn't there? And that's another thing that definitely does kind of come under the barriers related to stigma and discrimination, is the fact that if people are disclosing their drug use in the first place, and so then if they're not, or this, that makes it very difficult, I guess, to then ascertain the risk there, and whether or not you'd be recommending a test or access to treatment. So I think, yes, if someone, you've got a relationship with that patient, they've disclosed that information, then I think it is much more straightforward conversation. I guess the other thing too is, and this is certainly something I've done in the past, is that it's not just people, like there's a lot of different reasons that someone has Hep C. We just recommend that everyone gets a one-off screening test, that kind of thing, rather than making it just about only people that just have Hep C. You can broaden that out, I guess, and just to say, it's reasonably common in the population, and if you think there's been any risk, it can be transmitted through a whole lot of different ways, and we really recommend getting a test as well, if they've not disclosed that.
Yeah, thank you. And that's just my thing there, is whether or not this should be a broad suggestion for people. But I suppose in time, we may come to the point of where if things, if we're not taking up screening and treatments and hence cures, then I suppose that's when we might have to address that a little bit more broadly. But yeah, just letting you know, at this point, we tend to not probably bring that up as much as we should, I think. That's just my personal opinion. It might be something that might be a bit more helpful. But anyway, thank you so much.
No, that's okay. And I mean, it is a really interesting topic, and I think this is a little bit what Jem is touching on, I guess, more in relation to Hep B, but it's also definitely a conversation worth having. And it's probably not, I guess, in the forefront of a conversation in the sector as much around Hep C, but definitely, should we just be screening everyone? There has been some studies done in terms of, especially people presenting to emergency department, should it just be a standard test that is done? And because it does then reduce the onus on the patient and the person to disclose information about risk, and then we're hopefully capturing a lot of people that are undiagnosed. So yeah, definitely an interesting one.
Yeah, sorry, and also might say they do need like information and informed consent before we even do these investigations.
Of course, and it's interesting because I'm going a little bit off topic here, but I think we obviously are all interested in Hep B, and especially for us at LiverWELL, it's our day to day, and so it's always on the forefront of our mind. And if you think about whether you may be going to the GP or hospital, oftentimes we get a full blood test, liver function test, your standard blood test. And yes, there's consent and you sign the form, but it's not necessarily something that goes into a huge amount of detail. And so then, in the past, as some of you may or may not be aware, there's been very stringent, I guess, consent procedures around testing for BBBs, especially for Hep C and HIV. And so there used to be, you had to do a whole course to be able to do the pre-test counselling and post-test counselling around this testing. And that was because, especially around HIV, it was obviously a very severe diagnosis, and Hep C also didn't have particularly good treatment options either. Now that both of those things have changed, the treatment and management for HIV is, significantly better and really positive, and also for Hep C treatment, that restriction has been taken off, but there's still obviously, for people, it can still be a really significant experience being diagnosed. So yeah, there's a lot to think about there. All right, so talking a little bit more about treatment. So I'm not a pharmacist by any means. My level of pharmacy knowledge is a bit dismal, but I do think it is interesting to talk about what DAAs are. We talk about direct-acting antivirals, and there's quite a few different medications. And so the two kind of, I guess, common ones that you might have heard of, there's Clusar, there's Maverat, there's a whole lot of different ones, but they all work in a pretty similar way. And what they do is, so the way that Hep C survives and lives in the body, very, very simply and generally, is by making proteins that make more virus, and that allows the virus to replicate and then live in the body. And what they do is the different medications target different kinds of proteins within the virus cells and within the virus itself. And then that disrupts their ability to replicate, which means that over time the viral load drops until it becomes undetectable and the virus is no longer living in the body. So that is just a very, very general overview of DAAs and how they work. So a little bit more detail on treatment. And some of those barriers that we've sort of started touching on. So as we mentioned, the side effects are significantly reduced. They're very tolerable. And in fact, a lot of people, a significant number of people will feel a bit off. If you've ever taken a course of antibiotics or any medication, you might not feel like quite yourself, but it's nothing terrible for most people. And also, a lot of people say that they actually start to feel better when they're on treatment, because what happens is that slow build up over time of, not feeling quite yourself, a little bit fatigued, a little bit, brain fog, That happens slowly. People don't even realise that they've not actually been feeling great, or that, you know, they're not feeling 100%. And when they start to take the medication, that kind of resolves, and people actually start, so they quite quickly begin to feel a lot better. Eligibility restrictions on treatment, pretty much there is none. There's, as opposed to what it used to be, where there were significant restrictions if you had a mental health diagnosis, a lot of medications were contraindicated. If you've been treated in the past, you know, if you were still using, if you were still drinking, you weren't able to access treatment. Thankfully, that had all changed. So anyone is able to access treatment. Generally, what we say is that, well, it used to be if you were over 18 with a Medicare card. Now, quite recently, there have been some medications that have been approved for use. I think it's up to maybe 15 or 16, but, you know, within the scope of a pediatric gastroenterologist and that kind of thing, but it is available to teenagers. But also the Medicare card thing now, there are avenues and options to access treatment for people without a Medicare card. It can be really tricky and it can be quite messy. It generally is usually managed either through like a refugee health clinic or the hospital in a tertiary setting and hospital pharmacies. But there are options there, just not quite as straightforward. Costs kind of go hand in hand with that. So this is something that I like to talk about because it is something, again, that feeds into some of that misinformation that people often come with. And so, being honest, the cost of the PBS for the medication is significant. It is, you know, tens of hundreds of dollars, a lot of money. But the thing is, so is a lot of medications on the PBS. That's why we're lucky to have the PBS available. It's not unusual that medications are very, very expensive without the PBS. And unfortunately, what has kind of happened is that people have either seen it printed on the labels of, you know, their friend or family medication when the pharmacy prints that out, or they've heard that, you know, these medications are so expensive. And it can sometimes lead to a little bit of a thing of either I shouldn't access that, or I can only do that once and it's a one-shot kind of thing, and I want to wait until I'm feeling, you know, completely stable and I've sorted out everything else until I access treatment. And that's totally fine if that's where they're at, of course. But we just don't want it to be because of the cost or because of the perceived cost. You know, the cost is depending on whether someone has a healthcare card, the cost of a script. You know, what is it? $40, $30, and $6 something for a healthcare card. That's what it costs. It is just the cost of a regular script as per a lot of medication. And that's the messaging that I really want to get out there, because it just isn't really relevant, at least in my perception, for patients to be, I guess, making decisions based on that information. Let's have a look at that question. Heard and occasionally doing that. Yes, that's very, very true. So whilst we really recommend that, obviously, medically it's quote unquote better and more likely to be successful if people take the full course of medication, it is definitely worth encouraging people who perhaps feel as though that, you know, whether you maybe think that it might be the case that they're not going to be able to take it every day, or they don't think they're going to be able to take it every day, it can still be really beneficial. And there's absolutely no harm really in giving it a go if people are happy to and want to. It can often be successful if people take, still, you know, they've got to take a decent amount, I would say, but it's definitely fine if people, it's fine, but it happens that people miss a day or two and it can still be really successful. And I think that's, you know, one of the things that we're looking at now as we progress into this next stage of how do we treat people that currently haven't accessed treatment yet. It's been really realistic and meeting people where they're at around what their needs are and what is, you know, still kind of recommended and supported to do within the realms of that. So yeah, that's a really good point. Thank you. And so that really actually leads quite well into my next point, is the fact that oftentimes, you know, when then a bit of a generalization, there's definitely people that fall in and out of this category, but for a lot of people perhaps who fall into the cohort of people at risk of Hep C because of injection drug use, there's often a lot going on in their life. They might have unstable housing, other really competing priorities, and there's a lot of systemic and structural barriers that can kind of mean that people just have a lot of other priorities rather than taking their medication. So you can imagine if you've got nowhere to sleep tonight, or you're not feeling well because you've not been able to go and pick up your medication, or, you know, all of these stuff, something that might impact you 30 years down the track and you feel absolutely healthy today probably isn't going to be a priority. And so it's really about how can we support people either to address some of those more broader systemic barriers and kind of, feel comfortable that they're a place where they can access medication, or like what's coming through the chat now is that, what can we practically do to support people to get cured regardless? And so the other thing I wanted to talk about, which I have briefly touched on, is reinfection and retreatment. So as I mentioned, there's no way that you can be immune to Hep C. So if people do access treatment, then they can still, even if they've cleared their Hep C, it's still possible to get reinfected if there's risk there, and a risk for transmission. And that's, whilst obviously not necessarily great, it is not the end of the world by any means. And that is something, again, that we also really want to stress to people, because that can be quite a barrier. They think, oh, well, if I'm just going to get it again, it doesn't matter. There's no point in me getting treated. And that's not true. It's still really good for people to, I guess, clear the virus and give their liver that break. And who knows, what the situation will be in the future. But we definitely still want to be encouraging people to get treated, because treatment's available as many times as required. If people are reinfected, as much as we would like, hopefully be having conversation around harm reduction and reducing risk, if that is something that happens, then retreatment is available. And, we really would want to be encouraging people to continue to be getting tested if they're at risk, and not feeling like they can't or shouldn't because they've already accessed treatment. And treatment, it can be successful a few times as well. So I'm not sure if there's kind of studies out there about the max number of times that anyone's been treated, but we've definitely seen, people get treated multiple times, and it has been successful. There we go. All right, just on treatment. Did anyone have any questions on treatment? I'm just having a look at the chat now. Info above. Great. Thank you. Thanks, Wendy. Does anyone have any other questions about treatment or anything we've talked about just before I talk about pathways? All right. All right, so treatment pathways. So this is fantastic. We've got this treatment available, but how do people access it and where do people access it? And for some of you, especially, in the Gippsland area, you may be the clinic that does this, and this may be a fairly useless information for you. However, it is generally something that can be a bit of a barrier for people, because unfortunately, whilst availability to Hep C treatment and testing is increasing, it is still sometimes quite difficult to find people who are experienced and knowledgeable and have treated people in the past. And so if you're supporting clients and patients who maybe aren't sure where to go, this will hopefully give you a little bit of an overview. The first thing is getting a blood test and getting a confirmatory blood test. Even if someone's been treated in the past before, even if someone's been tested in the past before, and maybe they were diagnosed a year ago, 2 years ago, 10 years ago, they're still going to need a current blood test to be able to access treatment. So getting a blood test. Now, in general, in theory, all GPs or all people who can write blood test requests can request a blood test for Hep C and can test for Hep C. So that means that if someone is comfortable, they can go to their local GP and ask for a test. And so that is great in terms of access. Unfortunately, of course, for a lot of different reasons, people may or may not be comfortable to go and talk to their regular doctor about it, their family doctor about it. Also, not all GPs are familiar with or, I guess, particularly experienced treating and managing Hep C. So this is sometimes where we can see that, like talking about earlier, the antibody test, and also for people who perhaps blood tests can be quite difficult. If people's veins are very damaged, that can be quite a big barrier for people as well. Just all I know I've got to go and get all these blood tests, so that's difficult, and I'm not going to be able to get a successful blood test. All of those kinds of things. If people aren't sort of, I guess, sensitive and aware of those issues, then sometimes that's not always the most successful. And we do recommend people to perhaps try and go to a clinic where there's a high caseload of people who've been treated for Hep C, or they've got experience, treating clients in the AOD sector, that kind of thing. But it is useful to know that technically any doctor, person can order a Hep C blood test. on the basis of that, then it will either be recommended that somebody can get the fibre scan. Sometimes ultrasound is still used. In saying that, though, that's generally more around broader liver health management for actually diagnosing Hep C and therefore getting someone on treatment. Really, it's usually either the calculated APO test, which will be above or below 1, and then if because of that test, there's an idea that maybe someone's got a bit of liver damage, that'd usually be recommended to get a fibre scan. And then that sort of it gives a complete picture of what someone's liver is doing, what their Hep C is doing, and then they can get a script. And so again, it's how do we streamline this? Who can they go to? But scripts. So when the when the treatment was interferon and ribavirin, it was very closely held in terms of it in the specialist space because it was, a difficult treatment and quite nuanced. Fantastically, with these new medications now, when it first came out, there was, some courses people had to do, and then there was sort of a supervision set up. Now it's got to the point where technically anyone can prescribe the Hep C medications, doctors, nurse practitioners who are qualified in that space, that kind of thing. But again, a lot, especially GPs, a lot don't or aren't familiar with it. So it's just about finding the right GP or the right nurse who can help guide you through that and prescribe that medication. Also, just as a side note, ASHM have quite a good database on their website around GPs and nurses who are specialised in Hep C, and also being in a regional area, often there'll be 1 or 2 GPs or nurse practitioners in the area that are known for prescribing Hep C treatment, but it can be a little bit tricky sometimes. And then the pharmacy, so I think it depends on the area. This used to be a little bit more complex because there used to be quite a delay in being able to drop your script off and go to the medication. Sometimes that can still be the case though. So if somebody is, for example, on 12 weeks of treatment, sometimes they may need to put in multiple scripts. And so sometimes it's just worth flagging with people to maybe put their script in a few days before they run out of medication, because sometimes it can take a little while for the pharmacy to get them in. And then 8 to 12 weeks of treatment, depending on the medication. And then after that, what is really, really important, and I guess is the conclusion to the treatment pathway, is that the person gets what we call an SVR test, which is done 12 weeks after completing treatment. And that test is a PCR test. So it's the PCR test I talked about earlier, but it's what we call like the response to treatment test. And that is when that's negative, that means that treatment's been successful upon the 12 weeks after taking the last medication. That's a bit of an overview of accessing treatment. And it is in some ways really straightforward, quote unquote, in the sense that, it is you get a blood test, you get your medication, and then you get your test when you're done. And that seems straightforward, but of course, as we've mentioned, there are not always easy to find the right people, and there's obviously a lot of barriers in people's day-to-day life and knowledge and information and all of that can sometimes make that more complex than it sounds. So really about, I guess, supporting people through that and helping them find the right place to go. And encouraging that SVR test, that is really, really important. So that's the end of my content, but I'm more than happy, to take any questions or any comments and information that people would like to add as well. Anyone have any questions?
Is there any, it's Carol here.
Hi,
Is
Carol.
there any age that, hello, great talk, thank you. Is there any age as a cutoff that they cannot receive treatment? So if someone receives, like only in the 70s, finally finds out they've got Hep C, are they still able to receive treatment?
So, to my knowledge, the short answer would be yes. However, and that actually reminds me of a really good point, so thank you. It would depend on, I guess, their general level of health, what they were trying to achieve, what someone's liver health was like. Generally, I mean, if somebody has, even sort of cirrhosis, end-stage cirrhosis, they can still access treatment. It can still be really beneficial because what happens is that if somebody does have quite significant liver damage and they get treated, whilst, you may not get the same function back and the same level of repair to the liver that you might for someone that got it when they, barely had any damage at all, it still stops any further damage, and that's still really beneficial. And the medication just still really, really tolerable. And so, yeah, if someone's general health is good,
It's still worthwhile having a go, you're saying?
I think so. In saying that, though, that may or may not be, depending on the person and their health, one of the scenarios in which they would be treated by a specialist. And so that is something that I missed, so thank you. But there are some situations in which being treated by a GP or in the primary healthcare setting is inappropriate, and that there would still be referral to a specialist. And so that looks like things like potentially advanced stage and other health complications. If someone does have really severe cirrhosis and liver scarring, often that will be managed by a specialist. If there's co-infection, so if someone's living with Hep B, maybe HIV, all those kind of things, they would generally be recommended to be managed by or treated by a specialist. But yeah, definitely still available. There's no